Welcome to Respiratory Disorders Part 10. Finally, the last one. And this part of the lecture will be about asthma, something that you should be familiar with from your previous courses. Make sure that you watch the Khan Academy videos related to asthma that are already up on Blackboard prior to listening to this lecture. So as you know, the pathophysiology of asthma includes bronchospasm, allergy, and inflammation. So status asthmaticus is asthma that is unrelenting, no matter what kind of medical treatment is given. When these kids come in, we need to insert an IV immediately. We nebulize bronchodilators. We'll give systemic steroids, and for status asthmaticus, these need to be delivered intravenously. It's going to take too long for oral meds to kick in order to counteract the signs and symptoms of status asthmaticus. You need to place this child on a cardiorespiratory monitor. Have oxygen available as needed, as well as suction, and then know where the crash cart is and have intubation equipment at the ready in case it is needed. We want to catch these kids long before they get into this type of a condition. When you do the assessment of a child with asthma, you want to find out about cough. Are they short of breath? Do they have audible wheezing? And this can be audible with or without a stethoscope. What does their face look like? Do they have that anxious look because they're having such a difficult time breathing? Have you ever tried to breathe more than a minute through a straw? Try it. This is what an asthmatic has to contend with when they have no open airways. So there'll be dyspnea, a feeling of tightness in the chest that they can't get a good breath. There's going to be some form of labored breathing, and in the younger child, because of the pliable chest, this is going to be exhibited as retractions. In older children, you're going to see retractions that are going to be suprasternal and supraclavicular. You may also see nasal flaring. Some kids only have exercise-induced asthma, so they wheeze with any form of exertional activity. And then, of course, our severe cases of asthma can come in with cyanosis, looking pale. They may be diaphoretic because of the work of breathing. And do remember, just because you don't hear wheezing doesn't mean they're having a bad episode, that their asthma is not really the problem. They may not have anything going in and out, which is why you don't hear any wheezing. Assess their vital signs, and once again, we're paying attention to temperature because sometimes it's some kind of an upper respiratory infection or any other kind of infection that's triggering this episode of asthma. Look at their heart rate, look at their respiratory rate. What is their pulse ox doing? If we can get them to take a big enough breath to blow into a peak flow meter, we want to do that because this is going to be our initial assessment in anything that we do to them in a clinic, even at home, as well as in the ER. Indicators for admission are going to be based on pre- and post-treatment peak flows. Is this child interested in their environment? Are they responding appropriately? And if they aren't, that is an ominous sign. Listen to their chest for adventitious breath sounds, and you'll hear wheezing. And if they have a concomitant pneumonia, there also may be decreased breath sounds in certain parts of the lung. And then when they're not moving any air, there's going to be a decrease in their breath sounds. Depending on how bad an asthma attack is when they come in to see you, we also want to assess the knowledge that the parents have about asthma, and what does the child know also, what treatment modalities have been used, and how compliant have they been with the treatment, as well as using the peak flow meter to indicate that they're starting to have a bad day. Indicators that we're going to hospitalize a child is if their peak flow result is less than 50% of what we expect. If you hear inspiratory and expiratory wheezing, are they tachycardic and tachypnic? Are they having dyspnea with retractions? And are they not able to maintain their O2 sats above 91% despite all of the treatment that we've given them thus far? So this would be a child that's going to be admitted. The majority of these kids, when they hit this level of distress, will be going to the ICU. But if there is no pediatric ICU, they will come to a pediatric floor, and this is another child that needs to be very close to the nurse's station. It's important that you recognize signs and symptoms of impending respiratory failure in a child with asthma. Severe retractions and nasal flaring, that increased work of breathing that just doesn't go away. An uneven respiratory effort. They've been breathing so hard that they're now fatigued and they're giving up. An expiratory phase that doesn't end until the next breath, and this kid will not be able to talk and breathe at the same time. Severe to absent wheezing in a known asthmatic because there's no air exchange whatsoever. If they have the hyperinflated lungs, that's obvious, so they look like they actually have a barrel chest. When the child starts becoming combative, inconsolable, and then moves on to lethargy or somnolence, this is a bad sign. When we treat the child with everything that we have available to us and there still isn't good response, that child is ready to have a respiratory arrest. And then we have our pH and our CO2, O2 parameters, and when they're flipped from normal, this child is getting ready to go. And of course, cyanosis. So when we look at the plan and the nursing interventions, it's first of all, does this doctor want to admit this kid or not? We need to get respiratory therapy involved, and they will be in to do the nebulizers. But if they're real busy, that's going to be your job. And you need to know how to set up a nebulizer. If you don't know how to do that, go to the skills lab and practice. Know how to use the peak flow meter and to be able to read it. So we want to get that peak flow before treatment and after treatment and record the results. The medications we use for rescue are going to be your short-acting bronchodilators, primarily albuterol, and this can be given as a meter dose inhaler or it can be nebulized, and it's preferred to be nebulized. With a nebulizer, we can also give oxygen. We can give steroids IV as well as oral, and like I already said, the IV is going to kick in much sooner than the oral. The oral form is Solumedrol. You need to also consider the side effects of steroids, and I'm talking about the short term, especially when we give it orally. It causes GI upset. And for this reason, you will see some type of a PPI on the MAR, and you wonder, well, why do they need a PPI? Well, some of them actually end up having GERD as a separate problem, but most of these kids that are on steroids are going to have gastritis develop, so that's why we give it. For long-term control, we're going to use inhaled steroids. So Pulmicort or Flovent is an example. We can use long-acting bronchodilators in the form of Ceravent, and the leukotriene modifiers are now indicated for young children down to the age of 2. They're quite safe, but keep in mind, these particular medications for long-term control are never used to rescue when they have an acute flare-up of asthma. They need to use that short-acting bronchodilator. And if that isn't working, they need to be seen. So as I've told some of you during Skills Lab, asthmatics should not die. And I think that we have done a very poor job of teaching our patients when an asthmatic person does die. And this is a child or an adult. You need to assess and reassess your patient while they're in front of you. Administer oxygen. Give them IV fluids. if they can't tolerate oral. If they can tolerate oral and they're getting more comfortable with breathing, we want to push the fluids. Your patient and parent education is huge every time they're in front of you. This is one of those illnesses that's similar to diabetes. You need to assess and reassess their knowledge and their compliance every time they're in front of you. Review the medications. What are the short term? What are the long term? What do they do as rescue medications? Teach them how to use that peak flow meter. What is normal? What is their green zone, their yellow zone, and their red zone? What do they need to do with the results? The yellow zone, they still need to contact their pediatrician or their pulmonologist. But usually these kids have a medication list. This is what I take every day. This is what I take when my peak flow gets into the yellow zone. And when I'm in the red zone, I not only take my rescue meds, but I also need to make sure I either go to the emergency room or I go to the doctor's office so I can be seen. These kids need to take their peak flow meters with them to school, and the school nurse needs to be notified that the child is asthmatic. If we know what the triggers are that cause the flaring of asthma, we need to help them modify their environment to reduce these triggers. But kids can have an asthma attack just from the winds blowing, when it starts to rain, those type of things. Notify others that are caring for this child of their asthma. This would include the teachers, the coaches, babysitters, as well as relatives. This slide has a variety of YouTube videos that you can watch regards to peak flow meter readings, tells you how to actually use it, other medications that can be used. Actually, there's no YouTube video for that, but the way that they can be administered is. So we have the aero chamber spacer, if you're not familiar with it, as well as the nebulizers. We do have asthma camps, asthma support groups, and internet-based support groups available for these children because asthma can be crippling and it does affect their activities of daily living. So this ends the lecture videos on respiratory and ENT disorders.